everyone. Thank you for attending tonight's Ask the Experts virtual event, Relieving Joint Pain. I'm Dr. Matthew Darren, orthopedic surgeon specializing in hip and knee procedures at the Cleveland Clinic. Joining me are orthopedic specialists from the Cleveland Clinic. We are proud to be recognized in the United States and throughout the world for our expertise and care. Our surgeons perform more than 7,000 hip, knee, shoulder, ankle, elbow, wrist, and finger joint replacements per year, one of the highest volumes in the United States for severe osteoarthritis and rheumatoid arthritis, trauma, and other conditions. If you are in need of orthopedic care, we are honored to see you. We are here tonight to answer your questions, to share our experience, and to provide clinical insights on tips to keep your joints healthy, surgical versus non-surgical options, new treatment options such as same-day joint replacements and robotic-assisted surgery, how to know if a joint replacement is right for you and when to seek a specialist, what you can anticipate after joint replacement surgery. We had over 374 questions submitted by our audience, so we will do our best to answer as many questions as we can here. We will also send out an email after the event that includes other orthopedic resources. If you still have any questions after this event or are interested in learning more, please call 866-275-7496. With all that said, let's take a few minutes to do introductions, and then we'll dive right into the question and answer portion of our event. To kick things off again, I'm Dr. Matthew Darren. I'm an orthopedic surgeon. I specialize in hip and knee procedures at the Cleveland Clinic and also tonight's moderator. I've been in practice for 6 years. I see patients at the Mentor Hospital, Euclid Hospital, and Main Campus. And I operate both at Mentor Hospital and Main Campus for knee and hip replacements. I perform robotic knee replacements and anterior total hip replacements, as well as revisions and treatment for paraprosthetic joint infections. The most common issue that I see is probably hip arthritis. And the most common question that I get from people often is one surgical approach better than others? Many patients have heard or have family members that have had an anterior approach in the past and may have heard that it was faster recovery or better surgery than other approaches. And my answer to this, that is my surgical technique of preference, but I think any approach, if done well by an experienced surgeon, is better than any experienced surgeon or a surgeon not experienced with an approach. In my experience, the patients that undergo the anterior hip replacements tend to get better a little bit faster, but long-term outcomes for both anterior, posterior, and lateral approach for hip replacement surgery are great no matter how you do it. So next on the panel, I'd like to introduce Dr. Wahid Andazari.
Hi, Matt. Thank you. And thank you for having me on this nice event. And I want to say hi to all the other physicians and also patients who are on the call. On the way of introduction, my name is Wahid Andazari. I'm the shoulder specialist, one of the shoulder specialists at the clinic. This is my 11th year here, including training, and I'm passionate about everything in shoulder, starting with sport injuries, going to rotator cuff related problems, severe arthritis in the shoulder, instability, dislocations, fractures, and I perform rotator cuff surgeries and shoulder arthroplasties and treat fractures in the shoulder. And also a portion of my practice is dedicated to patients that have failed surgeries or failed arthroplasties that will need revision surgery. I'll perform my surgeries at Main Campus in Twinsburg, Marymount Hospital, and also see patient in Independence, Main Campus, and Twinsburg office. So one common question that I will get is that why should I have my surgery done in Cleveland Clinic? And I think what speaks to that is, like, most of the time when we're said and done with taking care of patients, I ask them what part of the experience you like. And besides the fact that their problems are taken care of, I think the main important thing is for them that we work as a team here in Cleveland Clinic, and you get taken care of by every person at the highest excellence level. And I'm excited for the panel discussions that we're going to have tonight. Thank you.
Well, thank you, Dr. Andazari. And on the topic of team, our next panelist that I'd like to introduce is Dr. Samantha Figgis, Doctor of Podiatric Medicine.
Hi, I'm Samantha Figgis. I am a podiatrist in terms of education. I've also done an extensive fellowship in reconstructive foot and ankle surgery as well. I've been working at the clinic for, this is my third year, but I also did my training at the clinic as well. So I've been kind of around all the main and regional hospitals. Currently, right now, I'm working down in Akron and Mercy down in Canton, and out of the Akron General Surgery Center. And I treat everything from toes to ankle. I think probably the most common question I get tends to be about people's bunions and if they should have surgery on them or not. And I think when we'll probably get into this a little bit later on in the talk, but one of the things is bunions are a little bit more complicated than just a little bump on your foot. So in terms of if surgery is right for you, it's definitely something to have evaluated by a foot and ankle surgeon or a podiatrist just to see if that is something that's the right thing for you, because there's a lot of non-operative treatments that can actually help a lot with your pain. Thank you for having me, and I'm excited to be part of the panel.
Excited to have you. I actually had a patient today who saw me for knee arthritis who mentioned her bunions and how she was going to get those checked out next. So there is a lot of overlap between all of us. The next I'd like to introduce Dr. Steliano.
Good evening, everyone. I'm Nick Steliano. I was born and raised here in Cleveland, Ohio. I went to Cleveland St. Ignatius, and I'm happy to be back in the area. I did a lot of my training out of the state. I am a hand specialist, and I chose hand surgery because it's the best anatomy. Sorry, everybody else. But it allows me the opportunity to work on people from 5 years old to 90 years old. I can work on nerves, tendons, bones. I do elective hand surgery for arthritis. I also see some pretty bad traumas. So it lets me keep a kind of a practice that touches all different aspects. I've been at the Cleveland Clinic Akron General for 1 year, and I practice downtown at the physician's office building at Akron General main campus, and then also at the Health and Wellness Surgery Center in Bath, right in Fairlawn. Probably once a day in clinic, patients come in with some kind of lump or bump, and they're wondering what is going on. We'll get into this a little bit later on tonight, but things on the back of the wrist, when people come in with bumps here, they tend to be ganglion cysts coming from your wrist joint. And a lot of times people say they have trouble when they extend their wrist. When people come in with some nodules or bumps on the palm, that tends to be Dupuytren's, which we're going to talk specifically about. That's also my favorite thing to treat. And then sometimes people come in and they say, I got these bumps on my knuckles right here. And those often come from arthritis, and they can either be bone spurs or mucus cysts, but lumps and bumps are one of my favorite things, and I see them often.
Well, thank you all for your introductions. Now it's time to finally answer questions. Again, we received more than 374 questions, including topics like when to consider a joint replacement, treatment options for pain, and more. So we'll attempt to answer as many as we can in the next 45 minutes. The first question is actually for me, I guess, and it is, what are the non-surgical knee options before a knee replacement? And I think I like to tell all my patients that are suffering from knee arthritis, we kind of have two options. There's the surgical option, which is the complex thing, and then there's the non-surgical option. And I fit everything I can possibly fit into that non-surgical option. So if we were to kind of pin down the things that tend to help people the most, corticosteroid injections into the joint tend to be the most efficient, effective, kind of low-cost treatment that there is. Those tend to help reduce pain and swelling in the joint, and they can, especially for early arthritis, can delay the need for a knee replacement even years at a time. We also treat people with physical therapy because the quadriceps muscles and the hamstring muscles are stabilizers of the knee joint. And in an arthritic knee that can have a little bit of instability, by providing stabilization of those joints, we are able to control some of the pain from the arthritis from that. So physical therapy is a good starting point. And if people progress to needing a knee replacement, having strong quadriceps muscles is essential for your recovery, as it's a surgery that weakens your quadriceps when we do it. So having that therapy done beforehand only helps people. Other things like anti-inflammatory medications, when you need them, things like Aleve, ibuprofen over the counter work very well. Even Tylenol dosed appropriately can help with pain from knee arthritis. Then there's other things like braces, and there's things called gel or hyaluronic acid injections that we can perform. That tends to be a series of 2 or 3 shots that we give to patients. And these are all kind of the things, and a lot of times I'll tell patients, probably not one of these things is going to work in isolation, but if we try a couple of them at the same time and any one of them stick and help, then that's really what we're going for. We're trying to avoid the big thing, which is surgery. And if we need to do it, if these things fail, then surgery is kind of the next step. And I think I always think of it as the last step because there's no going back from it. So the next question will be for Dr. Andazari. What non-surgical treatment is available for chronic shoulder pain, and when is it best to just do physical therapy or have injections versus surgery?
Thank you, Matt. A lot of things that I will talk to are kind of we share between different joints when we talk about non-operative treatment. Shoulder tends to be the second most common reason patients seek orthopedic care in the office, and it's very common. And the first thing I would say is it's very important for us to understand where the chronic shoulder pain is coming from. Your doctor will get some basic evaluations, including x-rays and physical examination, and that provides some clues that where this pain might be coming from, and that guides them to potentially order more advanced imaging and pinpoint, is this an arthritic type pain, or this pain is coming from the rotator cuff, or you're having early stages of a frozen shoulder. And those are very important distinctions early on in the treatment process. As you said, physical therapy is the mainstay of non-operative treatment. And I like to explain it very, in simple terms, is like the way physical therapy works is that by strengthening the structures around the shoulder, each and every muscle and tendon tends to work less hard. And so the pain and discomfort associated with that structure gets lessened. One thing about physical therapy is that it works very slow, and you at least have to do about 6 weeks. And by doing a week or 2 of physical therapy, you might not see the benefit. And sticking with it, and a lot of time, consistency is more important than intensity. So you want to do the repetition and exercises over and over. Anti-inflammatory medications you mentioned are important, but the problem with them is that you're essentially taking a systemic medication to address one joint, and sometimes you have to worry, watch for the side effects. Consult with your primary care physician if you have a kidney problem, you're on a blood thinner. These side effects might be serious. And finally, cortisone injection, we use it a lot in the shoulder. You have to use it judiciously and make sure that you're not masking a real problem that needs surgical or closer attention, different treatments by just putting cortisone. That when I tell to some of my patients, it's a news to them what multiple repeated cortisone injections sometimes makes the disease process worse. You might, have a small tear that you just by repeating cortisone, you might turn it into a bigger tear that now it's not repairable. And my rule of thumb is that 1 or 2 injections should manage your symptoms per year. And if you require anything more than that, that means that you need a different treatment modality.
Thank you, Wahid. And the same thing holds true when it comes to the knee. You certainly don't want to you wouldn't want to do too many injections. A lot of times patients will see decreasing efficacy of those or improvement from those injections over time. And that's sometimes when we in the knee, and I imagine you in the shoulder as well, will transition patients from that conservative treatment to maybe talking more about surgery.
Absolutely.
So the next question will be for Dr. Figgis. The question is, I've sprained my ankles through my lifetime many times. Now I'm suffering from terrible ankle pain all the time. What can I do?
Thank you, Matt. So ankle sprains are probably one of the most common injuries that we see. Probably up to 30% of those patients will experience some type of chronic pain or instability after an ankle sprain. And sometimes it's whether something was, not treated appropriately from the beginning. If you never happen to see someone, you just said, "Oh, I sprained my ankle. I'll get better. I'll be fine." Or some people just don't fully heal and don't regain their strength and stability. So it's not uncommon for me to see people in my practice with chronic pain or instability or both after these types of injuries. First thing that happens when you come in our office is we take an x-ray. We want to make sure that there's no old fractures that, might have occurred at the initial injury that's causing some of your pain. Or sometimes if this is a long-standing issue, rule out any type of arthritis, because obviously those treatments would be different than the typical recovery from an ankle sprain. And then initial treatment, as long as your x-rays are negative, we're starting with basic things such as bracing, anti-inflammatories, and of course, physical therapy. I think this is going to be a theme going across the night, especially with physical therapy, and whether it's an acute ankle sprain or chronic symptoms after, it's really important to get that neuromuscular training back. So kind of what we've already talked about in terms of strengthening everything around that joint and strengthening the things that were damaged at the time of your injury. And then working on what we call proprioceptive training, which is your stability or your body's awareness in space. And that's extremely important when it comes to ankle sprains and regaining that stability and not feeling like your ankle is going to give out on you all the time. When that stuff fails, then there are surgical treatment options for chronic ankle sprains. There's times where your ankle ligaments don't fully heal, or you might have damage to the tendons along the outside of your ankle, or cartilage defects in your joint that happened at the time of the injury that never fully healed. So when conservative treatment doesn't provide you relief, we're looking at getting an MRI to kind of see what damage you're looking at to determine what would be the best surgical treatment option for you. And surgery, depending on what we find on the MRI, is anything from repairing the ligaments that never fully healed, or sometimes actually augmenting those ligaments with what we consider like really thick suture, or I guess rope and some anchors in your bone if there's not a whole lot of that ligament left, kind of creating a seat belt or a check rein to the outside of your ankle, so that you don't feel like it's always giving out on you. If you have any tendon tears, we're fixing those as well. And then if you have anything going on in your ankle joint in terms of cartilage defects or cysts or anything like that, a lot of that at times we can treat those minimally invasively with an ankle scope. So everyone's kind of heard of doing scopes for the knee, and we can do it in the ankle. We just have smaller instrumentation, and we stick a camera through one small little incision, and then our other tools and through the other one, and we can fix cartilage defects and clean up anything kind of impinging the ankle and causing some pain that way. So there's a lot of treatment options in terms of chronic pain following ankle sprains, and it's not necessarily something you have to live with. We just have to work through conservative treatment, and if all that fails, then we start looking at some type of surgery.
Great, thank you very much. Actually, that coincidentally could have been my own question, because I've had quite a number of ankle sprains in my life. But the next question will be for Dr. Steliano. I am starting to have, this one's not me, but I am starting to have joint pain in my hands, stiffness when I wake up in the morning. Do you have any suggestions?
So part of this depends on what's actually causing that pain in your hands and that stiffness. Most of the time, we'll be talking about arthritis in the hands, and it tends to be the end joints. So these knuckle joints right here at the end of your fingers, those undergo the most force. And so those are the ones that increased risk of having some of that cartilage breakdown. And then you get some bone spurs there, and it's harder for those joints to move smoothly. So you have decreased range of motion. There's also the chance that this could be carpal tunnel or a trigger finger. We're going to get into those later as well. So focusing on arthritis, I think the first thing is just to stay strong and stay active. So keep using your hands. You know, the less active you are with these fingers, as you move them less and less, they get stiff. And so I encourage people to keep using them, keep the range of motion. Sometimes my patients, like at the end of the day, they'll put their hands in warm water and move them back and forth. Oftentimes in the morning, this can help as well, especially if you're stiff in the morning. Sometimes arthritis will cause swelling of these joints. And you can imagine if your finger is real swollen, it's going to be difficult to move it as well. And so if we can decrease some of that swelling, we can improve your range of motion. So at night, some people will use a wrap, like a Coban wrap, around their knuckle joints. And so in the morning, when they wake up, they won't be as swollen. And if they're less swollen, they'll be able to range the fingers better to increase their movement. A fingerless compression glove can also be helpful. And you can pick those up at Drug Mart or on Amazon. The other thing that we can try is a Voltaren gel. And this is a non-steroidal, so just like people have mentioned before, Aleve or ibuprofen, but it's in a gel form. And your finger joints, they're pretty close to the skin. So what people will do will be to rub in this gel at night, sometimes put a wrap over it as well, and then it lets that medication seep into the skin and go into the joint to kind of decrease some of that inflammation. In relation to that, you could try a non-steroidal pill like ibuprofen or Aleve, or sometimes a meloxicam once a day. Now, the next step, treating those arthritic joints, we could try a steroid injection, and those go directly into the joint, and that's a great way of decreasing the inflammation there. After all that, the last step would be surgery, but if you do surgery on an arthritic finger joint, it tends to be fusing it. So the pain goes away because there's no more grinding of that bone spur, bone on bone, but the finger doesn't move anymore. And so there's a trade-off there, and we always keep that for the end.
Great, thank you very much for that. And the next question is actually for me. Is robotic-assisted surgery better for knee replacement than regular surgery? And are there any requirements to qualify for it? So it's a very good question. I do perform robotic knee replacements. And from a general standpoint, when we look at the data on thousands of patients that have undergone these surgeries, what we can find is that there are some advantages to robotic-assisted total knee replacement. The first advantage from a research perspective is that it is shown that the knee replacement components are placed more accurately. And so by using the robot, we can make our cuts much more accurately than conventional techniques, which involve cutting jigs that go either inside the bone or outside on the ankle. So that, in theory, I think years from now, that could translate into less wear and less loosening of knee replacements if they're aligned and balanced correctly. I think the other benefit to robotic knee replacement, which has been supported in the literature so far, is little faster recovery, a little less pain post-operatively. This probably comes in the order of 2 to 3 weeks of improvement in symptoms for patients post-operatively. And I think that's pretty true. Although the amount of pain that people have post-operatively is variable, in general, I do find that the patients that have the robotic assisted, for the most part, tend to have a little less pain. They may recover just a little bit faster. But when we're talking about things like pain, And if we can do anything to lessen pain after a big surgery like this, I think it's advantageous to do that. The last true benefit from a research perspective, from scientific perspective, is soft tissue injury. So the robot really allows us to cut only what we need to cut. So the ligaments surrounding the knee, the blood vessels surrounding the knee are all outside of the area where the robot will cut. And that makes safety a really important issue when it comes to robotic assisted. I think and this is what the literature has also shown as well, is that you're less likely to damage other structures, which is a good thing, because damaging other structures is more surgery, more recovery, maybe more protocols and restrictions after surgery while you're healing. And ultimately, if we're able to do less with cutting of soft tissue and dissecting things, and that amounts to less cutting is less pain. And I think it kind of fits hand in hand. There's really no requirements, so to speak, for one to be a candidate for a robotic assisted total knee replacement, other than the fact that depending on the system and the manufacturer, you may need a CT scan before surgery. For the most part, these CT scans have been covered by insurance, but occasionally insurance can kind of give us a hard time as to trying to get them approved. Some systems don't require a CT scan preoperatively. There's several major manufacturers that have robotic knee systems. But other than that, the only other thing that I would say is that they have not really been approved by the FDA for use in revision surgery yet. So people that need revision surgery, at this point, we're unable to use the robot, or it is not FDA approved to use the robot to revise their knee replacements. And not to say that manual techniques of knee replacement are really bad. I think we have done a good job of doing knee replacements, and they have improved over time, and our techniques are good. But I do think that the robotic assistant give us a little bit more accuracy, consistency. And when we talk about knee replacements, what we're really looking for is consistent results every single time. The same result, the same excellent result every single time. That's why I prefer to use it. So the next question that will be for Dr. Andazari. I've heard that rotator cuff surgery and recovery are difficult. Has that improved in recent years?
Matt, that's one of the very common questions I get from patients. And the honest answer is yes, there is some pain involved in the rotator cuff surgery. But I think if we understand that the shoulder is the most unstable joint in the body, and a lot of times it's really difficult to really rest. You can't really brace it. You can't really put it in a cast. And I would say the first thing that in the recent years we have been accomplished is that we have better and more comfortable braces that we put patients after surgery that allows immobilization of the shoulder better, and that controls the pain after surgery. And we have moved to a multimodal pain control after surgery. And that means that I personally start patients even before their surgery start the day before with extra strength Tylenol, and they come into their day of surgery with some medication on board already. And we use what we call peripheral nerve blocks and catheters, and they allow the numbing medication to slowly going around the nerve. These are procedures that are done before the rotator cuff surgery by our anesthesiologist under ultrasound guidance. And these catheters and blocks allow the patient to go through the surgery and come out with almost no pain after general anesthesia that they need for surgery. So I would say, despite having these blocks, I still recommend my patients to start taking their pain medication after surgery, and keep a small dose of pain medication on board, so that the transition off of the block becomes much more smoother, and they don't go from having the block on board to when the block wears off the pain comes with, and they're there with no protection and no pain medication on board. So, and then one more thing that will help is that swelling usually intensifies the pain that the patients experience after surgery, and staying on top of using ice at the site of the surgery and doing 20-minute ice on the shoulder, 20-minute off, at least for the first week after surgery, will keep the swelling down and makes controlling of the pain easier. Things like sleeping in a recliner chair allows you to have better positioning of the shoulders. Some patients want to go back to their bed right away, but we discuss and say that the upright position keeps everything under gravity and stable, and there will be less tossing and turning during the sleep, and recliner will be, for the first few weeks after surgery, will be the best place to rest. And what I personally find in discussions for surgery with the patients, that I take time with patients and explain to them what their experience is going to be. And a lot of times I feel that setting expectations and preparing the patients mentally as what's going to come their way and helps them. This is my common question at 3 months when everything is all said and done and they are doing well after the surgery, is that how did it go? Like, would you go through the surgery again? And would you do it again? And I would say most of the patients will say, I was in a lot of pain and the surgery had some pain associated, but I'm happy I did it because now I can move on and heal. And I think the episode of surgery, the pain around that period to some extent protects you, and we don't want to kill all the pain so that things will the shoulder will be in a bad position, and that level of like 1 to 4 pain that we're talking about is actually protective for you after the surgery.
Great, thank you, Dr. Andazari. I think the point of preparation before surgery is a great point. And, nobody, myself included, I hate surprises unless they consist of presents and cakes. So we don't really want anything like that when it comes to our shoulder surgery. The next question will be for Dr. Figgis. What are the treatment options for heel pain?
That's a great question. So heel pain is probably one of the most common things I see come into my office. The most common cause of it is plantar fasciitis. So your plantar fascia is, think of it like a ligament or a band of tissue on the bottom of your foot, and it goes from your heel all the way to the ball of your foot. And it's overuse. So as we do more, we're on our feet more, that plantar fascia will tighten up. And so and your sleep at night, everything tightens up. You go to take those first steps out of bed in the morning and you're feeling this sharp shooting pain right through the bottom of your heel. And that's because that plantar fascia is tight and it just starts pulling as soon as you put your foot down and your arch kind of flattens out. And so what happens is usually that pulling or tightness, as it pulls on your heel bone, it'll create inflammation and even sometimes little tears in your plantar fascia. And that's what causes that heel pain on the bottom, like especially with first steps out of bed, or, you've been walking around all day, you sit down for a little bit, you go to stand up and boom, you have that really sharp pain right at the bottom of your heel. Plantar fasciitis treatment is pretty basic at the start. Simple things like stretching your calf muscles. When your calves are tight, that causes your Achilles to be tight, which causes your plantar fascia to be tight. It's all connected. And so just by simply stretching out your calves, whether it's, hanging your heels off of the stairs or kind of leaning up against the wall, but anything to kind of stretch that backside of your calf muscle there can kind of help to stretch everything out, release some of that tension, and not make your plantar fascia so tight that causes some of that pain. Anti-inflammatories, again, whether it's things like icing or topical Voltaren gel or oral anti-inflammatories like Aleve or ibuprofen can be helpful just to decrease that inflammation. Sometimes, we don't think about our feet until they're really getting in our way. So, people kind of push through some of that pain and then the inflammation builds up. And even with stretching and supporting that plantar fascia, without getting that inflammation away, you still continue to have that pain. So some type of anti-inflammatory is helpful. And then arch supports. So this is probably the question I get all the time is, well, what kind of arch supports? Because you go to the drugstore or Walmart or shoe store, or you're looking on Amazon, and there's a whole host of different arch supports. My favorite arch support is something a little bit stiffer. Something, it seems counterintuitive because you think, oh, I have the sharp pain in my heel, I need some gel, I need some cushion. And you actually just need more support, because what the arch support does is, if you think of, so this is your arch, and when you go to stand up, your plantar fascia is going to try to do this. And what you want to do is have an arch support, so a stiffer support that sits up in that doesn't allow your plantar fascia to stretch out. And then you don't get that pulling on your heel as much. Where if you take an arch support, I tell my patients this all the time, if you take an arch support or your shoe and you can bend it with your fingers, it's probably not supportive enough for you, because most likely when you're walking, your body weight's a little bit stronger than your fingers are, and you're probably just going to bend and power right through that arch support. So you actually want an arch support in a shoe that's relatively stiffer, because that's what's going to give you the support to the plantar fascia and not allow it to pull and cause that pain. I tell patients all the time, if you have heel pain, try not to be barefoot. So you step out of bed in the morning, have at least some house shoes there, or if you don't like to walk around in your house with shoes on, put a pillow on the ground and step on it. It allows your plantar fascia to adjust, and you don't get that really sharp pain first thing in the morning. If things like that aren't working for you, that's usually when people are starting to come in to see me. We obviously get x-rays, rule out anything going on with the bone. But other things that we can add there's simple things like night splints. This is kind of like a boot that you would wear at night. It holds your foot in a 90-degree position and just kind of gently stretches you out. Something that you can hold hours at a time, instead of the basic active stretches that you would be doing. Other things are, we do cortisone, our steroid injections in this area. Kind of the same discussions that we've already had tonight, in terms of we're limited to 2 to 3 of these a year, just because it can have effects in terms of kind of degenerating that plantar fascia, or even your fat pad on the bottom of your heel, and decreasing your cushion if you have it too often. And then physical therapy. In physical therapy, I try to tell my patients all the time, especially with plantar fascia, they think, oh, I'm stretching at home, I don't need physical therapy. What are they going to do there? And a lot of times it's more than just stretching. They have other modalities. One of my favorite things that a lot of my patients like is actually dry needling. It sounds very uncomfortable, but a lot of patients actually get a lot of relief from it. So there's other things that they can do to try to break that pain cycle for you, decrease the inflammation, and kind of loosen up that plantar fascia for you. It is very rare that plantar fasciitis and heel pain isn't treated with conservative treatments. I would say it's probably less than 10% of my patients, but there are those rare cases. And if that's the case, there are surgical procedures, anything from ultrasonic debridement of the plantar fascia, if it's kind of a more, less chronic case, I guess I would describe it. Or there's actually like plantar fascial releases, where we release part of the plantar fascia to loosen things up. And obviously, before any type of surgery, we're usually getting an MRI, because there are some things that can mimic heel pain, like plantar fasciitis type pain, where there's nerve entrapments or things in that area. So that's definitely one thing before having any type of surgery on your heel pain, getting advanced imaging to make sure that there isn't something else that's mimicking your heel pain that would be causing it.
Thank you very much, Dr. Figgis. That, I know that is a very common question, and I'm sure there's a lot of people listening today that are going to get some good information from that, because I've had a few family members even ask me about that one. So, all right, and the next question will be for Dr. Saturino. Satariano. What do I do when I have trigger finger?
Great question. One of the most common things I see. So first off, a trigger finger has nothing to do with shooting a gun. When people have a trigger finger, they tend to say, when I make a fist, one of my fingers clicks. I'm bringing it down and I feel the click to it. And sometimes if it's really bad, and they say, when I try to extend my fingers, it gets stuck and I have to physically open it up. So what's happening there is the flexor tendon is getting stuck in the tunnel. So we all have tendons, and when we pull the tendons, our fingers come down, and those tendons run in a sheath, and the sheath keeps the tendon running in line. And what happens over time, we don't really know why it happens, but that sheath gets pretty thick. And so the tendon no longer can glide. When you're pulling it, it kind of gets caught in the tunnel. And that's what causes the clicking as you're trying to pull it down. And when it's really tight, that's when it gets locked. And they have to actually open it up. And that often causes some pain. So the first thing I tell people is, we can just watch this. No one ever died from a trigger finger. It's not your heart. It's not your lungs. If it's not bothering you too much, we can watch it. Now, most people want something done. So usually the first step is the steroid injection. And the point of the steroid is I try to put it right in that tunnel. And the steroid acts to kind of grease the wheels, cuts down on the inflammation, and it lets that tendon glide more smoothly. For over 50% of people, a steroid injection typically does the trick. Now, if it doesn't work, if it comes back, we could always try a repeat steroid injection, but if this is a bad trigger that just keeps getting stuck, we can do surgery. And the surgery is pretty quick. We do it under local only, meaning I numb up your finger, but after that, you don't feel any pain. We go back to the operating room and I make a small incision right over where that tunnel is. I spread down and I look at the top of the tunnel and I just go snip, snip, snip. Open up the tunnel and I'm looking right at the tendon and then it glides. And the nice thing about doing it local only, meaning you're awake, is I will tell you, all right, game time, I want you to make a fist. And even though the finger's numb and you're not feeling pain, you can feel if it's still clicking and locking. And so I'll tell them, okay, bend it down, show me, try to make it click and lock. And if it's still clicking and locking, I know I need to cut a little bit more of that tunnel. But most of the time they say, oh, it's gliding okay. And if you're really into it, I can show you your tendon in the middle of surgery. And you can actually see it moving back and forth. And most people get a kick out of that. After that, I wash it out, couple stitches, and you're in a soft dressing for 5 to 7 days. I want you to keep moving it. There's no cast, no splints or anything like that. And if you type for your job, you can get back to typing in a day or two. If you do manual labor, I'll probably have you off for about a week. But most people get a significant improvement from a quick surgery.
Thank you very much, Dr. Steliano. That sounds like nice instant gratification, which I know people are always happy with, myself included. So
Me too.
the next question looks like it is for me. When will I have full use of my hip after joint replacement? That's a really good question. And the first answer is I'm gonna waffle on this one a little bit and say it depends. So in general, when I replace someone's hip, if all things go as planned, you can put full weight on that hip immediately after surgery. I don't give people any restrictions when it comes to range of motion. I just, actually my only rule is that you don't fall after surgery because bad things happen when you fall, not only to your hip replacement. It takes about 6 weeks for the bone to grow into those implants provisionally. And so once that happens, there's little you can do to kind of mess that up. It kind of becomes part of your body and you start to develop a pretty thick layer of scar tissue around it. So I usually tell people just take it easy for about 6 weeks. Don't give me too much. And what does take it easy mean? Well, take it easy to me probably means something different to everyone out there. For me, it means no heavy lifting, nothing too strenuous. And by too strenuous, I mean anything really more than walking or riding a bike gently, stationary bike. Things that I have had people do that probably weren't the greatest idea: climb underneath cars, up onto tractors, carry water heaters out of their basement, things like that. Those are the kind of things that end up getting you in a little bit of trouble. All those people ended up fine, but they were a little sore afterwards. The reason why we kind of slow people down a little bit after surgery is the same reason Dr. Andazari talked about a little earlier. A little bit of pain kind of modulates your activities, the body needs time to heal. And although your arthritis will be gone and your hip will be good, that tissue around your hip has to heal. The bone has to grow into those implants, so that way we don't have to do anything over. Some of my partners are a little bit different, some more conservative than others. Some of them will have you use a walker for a couple of weeks or partial weight bearing up to 6 weeks to allow the tissues around your hips to heal. Some will give you some restrictions as to where you can put your hip as far as range of motion to try to avoid dislocating it. Dislocation, fortunately, is not a huge issue, I'll knock on wood, when it comes to anterior hip replacements, although the literature says that the dislocation rate is the same for both anterior and posterior hips. I can tell you through personal experience, it's a much lower dislocation rate just because the position to dislocate your hip after anterior hip is kind of having your leg way behind you and externally rotated to 90 degrees, which is just not a position that we get into very often. Some people with more complicated hip problems, we'll have to restrict their weight bearing a little bit after surgery. And so I always think about this as we're given a little bit of time now, so the hip is good for the rest of your life. If you have a really complex bony defect, or your bone is very soft, or sometimes the bone can break during surgery, you have to fix it. Those things can slow you down, so we don't like you putting full weight on it for about 6 weeks after surgery. That's pretty rare though. So in general, I usually tell people, give me 6 weeks, you're gonna be feeling good by then. I'm going to be asking you to slow down just a little bit so that this thing can fully heal and you can have the best outcome possible. The next question will go back to Dr. Andazari. Can you tell me more about shoulder arthroplasty? Is it an option if I live alone?
Thank you, Dan. This is my favorite topic. I have to control my excitement a little bit. So shoulder arthroplasty is have revolutionized, the way we treat shoulder. We used to have to kind of repair things around the shoulder only, but when things get really extreme in terms of arthritis or torn soft tissue around the shoulder, it gives us a lot of options to address patients' problems. Shoulder arthroplasty, we do about 130,000 of them every year in the United States, and it's the fastest growing joint replacement of all the joints in the body. There are two general categories of shoulder replacement. There is like a regular or anatomic replacement, which if you assume the joint is a ball and socket joint, the ball and socket in the regular replacement are where exactly your usual ball and socket in the joint is. So the ball is on the arm side and the socket is on the shoulder blade side. And with this replacement, the requirement is really your soft tissue around the shoulder should be intact, meaning mainly your rotator cuff should be intact. And this is usually a case for a 60-year-old patient that has gone through, their joint has gone through wear and tear, they've had injections, physical therapy, and now they're finding out that that's not controlling their pain. And usually there's varying degree of stiffness involved in that disease process that prevents them from moving their shoulder normally. And that shoulder replacement not only replaces the lining of the joint on the ball side with a rounded metal, and on the socket side with a piece of specialized plastic made out of polyethylene that has very good wear characteristics and allows you to have gliding motion in your joint. The pain goes away, and I would say it's one of the most predictable surgeries that I perform, and I can predict week by week how the patients do after surgery. There's part of the surgery, we have to take some of the rotator cuff down, do the surgery and repair it, and hence the first 6 weeks, very similar to Matthew said, we want the patients to go slow after that surgery so that soft tissue heals around the shoulder and your body grows into the implants, and that allows you to have more durable outcome. The second type of arthroplasty is a reverse shoulder replacement, which we usually indicate patients who have more severe type of arthritis that allows that had a socket worn out, or the rotator cuff with soft tissues around the shoulder are severely compromised. And that usually ends up being patients who are in their 70s, had either prior surgeries in their rotator cuff or had advanced arthritis that now worn into the rotator cuff and the socket. And In that reverse shoulder replacement, we call it reverse because the relationships of the joints are changed. Instead of the ball sitting on the socket side, sits on the arm side, sits on the socket, and we put the socket deeper and to some extent turn the shoulder in a similar joint as hip joint. And because it's more constrained, allows the rotator cuff not to have to work harder, and the implant itself provides a stability and allows you to gain your overhead function. And both of these surgeries usually gives you pretty good pain control, and I usually quote that your pain at 1 year goes down to 0 to 1 after the surgery. And depending on where you start with the function, your function gets to about 70 to 80% of a normal shoulder, which is this huge improvement for patients. There was a small question at the end that says, like, can you have this surgery if you live alone? And one thing about the shoulder is that you don't walk on it, so it's a non-weight bearing joint. So what can happen is that after a shoulder surgery, you can put it in a sling and kind of not use your arm for that early, weeks after the surgery. So I would say ability of us sending the patients home, and now for the past 2-3 years, if you're not medically have to be in the hospital, you can have this surgery and go home the same day, which is a huge improvement in terms of not having to be in the hospital. And what recommendation I have for patients that having someone with you for the first 3 days after the surgery, and that mainly because you go to a general anesthesia, a lot of medical things that potentially can happen. But in terms of living alone, we can arrange for some people coming and helping you at home. But overall, a lot of patients actually have the surgery and gain independence, I would say, in a week or two after surgery, and they will need some assistance early on. I would say totally leaving alone and you have mobility issues, you might have to go to a facility after the surgery for a few weeks before you gain your independence. But generally speaking, as long as someone can stay with you for the first 3 days after the surgery, you can go home after the surgery.
Great, thank you very much. And the same is true. We had that same question about outpatient knee and hip replacement. It's the same exact answer, although you do have to walk on those joints. But it is safe if you don't have any other reason to be in the hospital. It's perfectly safe to go home after that surgery. The next question will be for Dr. Figgis. What can be done to fix my hammer toes?
Oh, hammer toes. Hammer toes are just they're contractures or kind of curling of your toes. And they can come in various different forms, and they can happen for many reasons. Everything from, oh, my mom, my grandma, my aunt had hammer toes and bunions. So oftentimes you will be at risk of getting them as well. They can come from old injuries that can lead to the toe contracting slowly over time. They can come from other foot deformities. So they're often seen with people that also have bunions as well, because that big toe likes to be a bully, and then it ends up popping up your second toe right next to it. Or certain people with neurologic issues, especially after strokes or things like that, can develop hammer toe contractures. So since there's a ton of different reasons, there's many different ways to kind of address what is going on. Unfortunately, once you develop the hammer toe contractures, there's not a lot of bracing or splinting that's going to necessarily be able to correct those deformities. If you're able to catch them early enough, especially after an injury, or, in terms of some of our stroke patients with neurologic issues, there are certain conservative treatments that can help to kind of keep them in a straight position and let them try to stretch out. In terms of splinting, or some of our stroke patients can end up having Botox injections to help to kind of relieve some of the contractures of their toes. Outside of that, for the most part, the only way to actually correct a hammer toe is to have surgery on it. However, we can accommodate the deformities very well in the types of shoes that we wear. So hammer toe surgery is not necessarily for everyone. And if you can accommodate it in the types of shoes you wear, then oftentimes you can actually avoid surgery altogether. So things like wearing shoes that have soft fabric on the top, so it prevents the rubbing on the tips or the tops of your toes. There are splints. So if your contractures are still flexible, we do actually have splints that can kind of hold the toes down. They only they only work while you're wearing them. So as soon as you take them off, your toe is going to go back to being contracted, but they're great for wearing inside of your shoes to prevent, rubbing and pain from those types of deformities. Things like padding or even just larger depth shoes to prevent, pain and rubbing on those also helps as well. If those things are not accommodating your pain and you continue to have pain no matter what types of shoes you wear, what type of padding, splinting you use, there are surgical procedures to correct your hammer toes. Everything from just releasing some of the tendons and soft tissue structures around it to actually removing parts of the joint. We are called arthroplasty, or actually fusing the joint, depending on how severe the contractures are, where we actually take the joint out and we stick a pin in and hold everything together. And then we could kind of talk for a long time on all the types of different procedures for hammer toes, but those are probably the most common ones. Oftentimes for this, you have a pin in your toe for about 4 to 6 weeks. So usually just means you're in a special shoe or a boot until those pins are able to be removed. So during that time, if it is your right foot, unfortunately you can't drive, but you can actually walk after your hammer toe procedures. So there's a lot of different things that you can do for these, and there's a lot of conservative care you can do to accommodate the hammer toe. But if those don't work, there's always surgery to correct them.
Thank you very much. And then we have time for one final question, which I think will be a good one for Dr. Steliano. I have curling and contracted fingers. What causes that, and is there any help?
So like Dr. Andazari with his total shoulders, this is Dupuytren's, and this is my favorite topic. So Dupuytren's is Viking's disease, and it tends to happen in people of Northern European descent. And this is something that goes on in your cells. So there's nothing you do in your life that causes this. And what happens is your cells in the palm are more prone to developing scar tissue. And that scar tissue feels like these hard nodules. They usually are not painful. But what happens is over time, usually they start in your 50s or 60s, you start to notice these nodules. They're pretty hard, and they start to grow into ropes. And they grow towards the fingers. And over time, as those ropes get more scarred down, they start to pull your fingers down like this. It tends to be the ring finger and the small finger. And so when I first see people, they'll say, hey, I have these hard nodules here, and I can't lay my hand flat anymore. I can't straighten out my fingers. They're actually pulling them down. And we determine our treatment based on how much deformity you have or how limited you are in straightening your fingers. Some people say, I can't put my hands in my pockets anymore. My fingers are getting caught. And so when it's a mild deformity, meaning you feel those nodules, but you're not functionally impaired, we just watch them and we watch the progression. Now, as they get more significant, as your fingers get more pulled down, then we start to say, what can we do about this? And the first option are 2 in-office procedures. One's called XIAFLEX. You may have heard of this or seen an advertisement for it. And XIAFLEX is an enzyme injection. And the cool thing about XIAFLEX is that enzyme only eats away at that specific scar tissue. So you get injected, we let the enzyme do its job for about 24 hours, and then when you come back into clinic, we actually kind of pull the scar tissue open, and it rips the scar tissue. This can be a little bit painful, but we do numb you up. The other option there is if you have a rope that's very defined and you can really feel it, like this is the one thing that's really pulling me down, I can do an in-office procedure where I use a little needle and I actually cut that rope. And you can hear it snap in the office. It snaps, your finger gets straight, and then I have you moving it again. Now, the thing with that is we haven't removed the scar tissue. We've only cut it to allow the finger to straighten. The final common pathway here is if you have bad disease or you come in and see me and your finger's all the way this far down, there's really only one option left, and that's surgery. And it's a more involved surgery. I have to make a larger incision, and I actually take out all of that scar tissue. So the key with Dupuytren's, or when you have these curling and contracted fingers, is you need to come see a hand surgeon to look at it. You need to come see me. And then we will monitor it over time, watch it progress, and we'll decide on the perfect timing when a procedure is right for you.
Perfect. I'm glad we could end on one that everyone was pretty happy about. So this concludes our Cleveland Clinic Ask the Experts event. Thank you so much for attending. We will send you a post-event email in the next day or so with important information about what you've just heard, links to all kinds of orthopedic resources, and details on how to make an appointment. It will also include a link to a recording of this event so you can view it again. Thank you again, be well, and good night.